This lecture is going to be on blood gas analysis. Of the tests available to assess acid-base status, this lecture is going to be on pH, bicarbonate, and PCO2, as well as PO2, which assesses the patient's oxygenation status. Blood gas analyzers require heparinized whole blood that has not been exposed to environmental air, so an anaerobic sample. If the sample has been exposed to air, then the CO2 evaporates and it causes a falsely decreased PCO2 and a falsely increased pH. The sample also requires rapid processing, and that's because the red blood cells in the sample will produce excessive amounts of CO2 in vitro. Blood gas results are partially dependent upon the patient's body temperature, so the body temperature should be taken at the time of sampling and then noted on the submission form. Venous blood gas samples are acceptable for pH and PCO2 measurements, but an arterial sample is required for evaluation of the partial pressure of oxygen, or PO2. However, arterial samples are rarely obtained in a clinical setting, and that's because 1, they're difficult to obtain, and then 2, there are easier ways to assess a patient's oxygenation status, such as the one shown here, which is a pulse oximeter. The bicarbonate buffer system is at the heart of blood gas interpretation, and that's because the 3 main components of blood gas analysis are within this bicarbonate buffer equation. The metabolic component is measured as bicarbonate. The respiratory component is measured as the partial pressure of carbon dioxide, or PCO2. And the blood pH is also measured. And the blood pH is under both metabolic and respiratory control. These are the 4 main blood gas tests. As previously stated, an increased pH means alkalemia, whereas a decreased pH means acidemia. An increased bicarbonate concentration means metabolic alkalosis, but if it's decreased, then that means there's a metabolic acidosis. Increased PCO2 means that there's a respiratory acidosis, but if it's decreased, then there's a respiratory alkalosis. An increased PO2 isn't really physiologically possible, so if it is increased, that means the animal's on supplemental oxygen. And a decreased PO2 means that the animal has hypoxemia. The partial pressure of carbon dioxide, or PCO2, is an assessment of alveolar ventilation. And the alveolar ventilation is the rate at which gas enters or leaves the lungs. So if CO2 leaves the lungs at a slower rate than normal, so we'll just pretend that this one arrow is a slower rate than normal, then that causes the CO2 to build up within the blood. This buildup of CO2 then causes the bicarbonate equation to shift to the left to reach equilibrium. Then there are increased concentrations of hydrogen ions, and this causes an acidosis. This decreased rate of alveolar ventilation is termed hypoventilation. You can actually induce a respiratory acidosis in yourself if you hold your breath. Hyperventilation is when the CO2 leaves the lungs at an increased rate. So there's lots of CO2 being exhaled. This results in a decreased concentration of CO2 in the blood, and then the equation shifts to the right to get to an equilibrium state. This then leads to a decrease in the hydrogen ions, and this results in an alkalosis. You can actually induce a respiratory alkalosis in yourself if you breathe very, very rapidly. There are 6 general causes of a respiratory acidosis, 4 of which are listed here. A respiratory acidosis can be caused by inhibition of the respiratory center, and the respiratory center is within the medulla. Various drugs can do this, especially anesthetic drugs, as well as primary central nervous system disease and metabolic alkalosis. All of those processes can lead to inhibition of the respiratory center. Upper airway obstruction can also cause hypoventilation and respiratory acidosis. So that's what's represented by the trachea. Common causes of this upper airway obstruction include laryngeal paralysis and also some breed-related conformational problems such as stenotic nares, elongated soft palates, and tracheal hypoplasia that you can see in some types of brachycephalic dog breeds. The pleural cavity, which is represented here in yellow, is nearly empty in health, but it can expand to much larger sizes in certain diseases. So it can expand and collapse the lungs and making the lungs unable to expand as much as they should. So things that can do this is pyothorax, hemothorax, chylus effusion, pneumothorax, or diaphragmatic hernias. So things that are in that pleural cavity that shouldn't be there. Respiratory muscle paralysis is an uncommon cause of respiratory acidosis. Dysfunction of the diaphragm, which is represented here by this red line, and also the intercostal muscles. Dysfunction of these muscles impairs expansion of the chest wall, and then therefore it impairs the expansion of the lungs. So causes of respiratory paralysis or respiratory muscle paralysis include tick paralysis, tetanus, botulism, myasthenia gravis, and also hypokalemia. The remaining 2 causes of respiratory acidosis are alveolar disease and vascular disorders. Alveolar disease may be caused by inflammatory cells or neoplastic cells within the alveoli, so that's a neutrophil that I drew. Or they could be neoplastic cells, so that's a angry neoplastic cells. And the mere presence of these cells actually physically impair airflow through the alveoli. And they also damage pneumocytes as well. Alveolar gas exchange can also be impaired by edema, so water within the alveoli. So I'm drawing some waves here. Or they can be impaired by fibrosis. So I'm going to draw some strands of collagen fibers here. Vascular disorders that can cause respiratory acidosis include pulmonary thromboemboli, so deposition of little thrombi within blood vessels that occlude blood flow, and also right to left shunts. And with right to left shunts, the lungs are bypassed, so the unoxygenated blood does not become oxygenated, and instead it mixes the unoxygenated blood with the oxygenated blood. So that's with right to left shunts. Respiratory alkalosis is not a huge concern by itself, and that's because it doesn't tend to cause life-threatening alkalemia. And also, pulmonary gas exchange is not impaired, so you don't develop hypoxemia. There is only one cause of respiratory alkalosis, and that is stimulation of the medullary respiratory center in the brain. However, this stimulation of the respiratory center can be a cause by a variety of things. So, a respiratory alkalosis does indicate the presence of an underlying disorder. It can occur secondary to low atmospheric oxygen, such as at high altitudes, or if an animal is under anesthesia and isn't receiving enough oxygen. Or it can occur with mechanical hyperventilation during anesthesia. If there's a primary metabolic disturbance that trends towards an acidemia, then hyperventilation can occur to help bring that pH back to a normal range. Hypoxemia is a decreased PO2. It is only a measure of dissolved oxygen in blood and does not include oxygen bound to hemoglobin within red blood cells. Disorders that cause hypoxemia are the same disorders that cause respiratory acidosis, with the additional cause of low atmospheric oxygen. Hypoxia is a decreased delivery of oxygen to the tissues. Hypoxia may be due to hypoxemia, but there are many other causes of hypoxia that do not alter the PO2 and therefore cannot be identified by blood gas analysis. Hemoglobic hypoxia is when there is a decrease in oxygen-bound hemoglobin, and the most common form of this is anemia. So, with anemia, you would not expect to see a decreased PO2. Stagnant hypoxia is when there's poor blood circulation, such as with shock or infarcts. Histotoxic hypoxia is when oxygen makes it to the tissues, but then at the tissues it's not used. So that can occur with cyanide poisoning. And then lastly, demand hypoxia is when tissues demand large quantities of oxygen. And this is seen with hyperthyroidism sometimes, and then also hyperthermia. So you don't need to know these various causes of hypoxia for this class, but you might need to know for your veterinary career. But what you do need to know is that hypoxia can occur without hypoxemia, and that anemia does not cause a decreased PO2 concentration.